Hi, my name is Dayanna Cavallo, and I am a DNP student, and my DNP project was on central line maintenance, policy revision, and review. The chair for this project was Dr. Moyer, and then the community members. The community members are Michelle Vanderveen and Sean Esperti. So, the background and significance, the aim of this project is to decrease central line infections in an inpatient facility. The researcher was able to identify an increase in central line infections in the neuroscience intensive care unit. And when there was an initiative to identify the problem, it was found that the central line maintenance policy was out of date and did not reflect current unit expectations. So the researcher decided to rewrite the policy and propose a new policy to the facility that they were at. So, some review of literature. There's several vital organizations that discuss the importance of central line maintenance and central line care. They have a lot of initiatives, they have goals surrounding hospital associated infections, which central line infections is one of them. And with these initiatives, they have care bundles and they have lots of research done and a lot of support around the importance of this central line maintenance. For these organizations, the Joint Commission, the World Health Organization, and the Center for Disease Control and Prevention, or the CDC, are a few of them. Now, back in 2020, the CDC reported 21,399 central line infections among the 3,687 acute care hospitals throughout the United States. And these infections are hospital-associated infections. So they get these infections from the hospital or, from poor central line care and maintenance. And there's other things too that these organizations stress, like scrubbing the hub and when to change IV tubing and when it's appropriate, how often it's appropriate to change central line dressings and how to change a central line dressing and the importance of being sterile upon insertion, and those all decrease central line infections. There are other research initiatives, which also include studies of various supplies, such as alcohol-impregnated port protectors for enhanced protection of central lines, and the articles that studied this are listed, or the references are listed below for that as well. For theoretical framework, it started with a problem presented on the neuroscience intensive care unit, and this was the increase of infection rates of central line infections. When the investigation was leading to why this was happening, it was soon discovered that the current policy for the entire hospital was outdated and uninformative, because what they were practicing on, the floor to maintain central lines was not necessarily wrong, it just did not reflect in the policy. And if anything, the policy was missing a lot of updates and new research initiatives for these central line infections that needed to be included. So the methods and designs, a quantitative method was used for this project, and it included the use of the appraisal of guidelines for research and evaluation too, also known as the AGREE tool. This AGREE tool is a tool that is widely known as an appraisal tool to properly evaluate and assess policies and clinical guideline practices. So any of the policies or guidelines that are written, most places use the AGREE tool to evaluate these policies developed. So there were 3 stakeholders, and they were also the appraisers for this guideline because they would be the ones to agree to adopt it into practice. They basically had the agree tool, which is they have 23 items in the agree tool that they must score. Each item being rated on a scale 1 to 7. 1 being strongly disagree, 7 being strongly agree. In these 23 items, the agree tool 2 were grouped into 6 domains. And then the total for each domain, so basically to get the percentages for each domain, there's calculations that will be discussed in further slides, and it is based on the appraiser's scores. So the totals from each appraiser were then added together to get a total score for the domain for each section. The agree tool 2, as I discussed, is a highly efficient and highly used method in clinical practice guideline evaluations. For reference, the researchers set a goal of greater than or equal to 85 for each domain to determine if the policy can be adopted into practice. Here's another methods and designs continued. This was my project timeline. The planning phase basically was the needs assessments and collaboration with the ICU manager. The literature review, I did a very intensive and conducted a literature review and identified pertinent themes, which included the themes to develop this policy to ensure that we are meeting all the standards set by these organizations such as the CDC, the Joint Commissions, the ones I discussed earlier. Then the approval phase, which was the Maryville had an IRB approval, and then the neuroscience ICU manager approval. Then the guideline was developed, and also some collaboration with the project chair happened here. Data gathering, the guideline was presented to the stakeholders, collaboration with the stakeholders, and I got the results from that. And then this is when after the data analysis followed the agree tool, and we followed the agree tool instructions, and the guideline followed, presented to the leadership. As far as the sample goes, there was no sample for this project. There were no test subjects, no individuals involved. It was only rewriting a policy review. The effects of the population that will be pertinent by this change are the patients in the hospital who received a central line. So patients will be affected, but they were not directly affected by this study. And this is the data analysis where I discuss how I calculated my numbers. So to get the scaled domain quality scores, the agree tool instrument instructions with the minimum and maximal scores were calculated, and then the equations were used by the researcher as seen below. So first, you need to get the minimum and the maximum scores. So for the minimum score possible, you multiply 1, which is the strongly agree, by the number of items within the domain, which are all different, and then times 3, which were the 3 appraisers. For the maximum possible score, you take the 7, which is the strongly agree, times it by the number within the domain, and then times 3, which is the 3 appraisers. The minimum and maximum scores possible were then used to calculate the scaled domain quality scores using the following equation. So the obtained domain total, which is whatever the appraiser scored it, minus the minimum score possible, divided by the maximum score possible minus the minimum score possible. Then you times that by 100, and you should get a percentage. The percentage was used to determine the quality of the guidelines and the ability to adopt into practice. So for each domain and each appraiser, their domain totals were calculated, and then the average was taken. from each appraiser. But the domain score percentage total from each appraiser was obtained by the agree tool instrument. And then the agree tool instrument also had a final 7-point score that asked the appraisers to rate the overall quality of the guideline in a selection of yes with modifications, or no. As far as the results go, the author decided to establish a threshold of less than or equal to 85% across all the domains. And these results, domain 2, 4, 5, 6, 1, 2, 4, 5, and 6, all scored 92 to 100%. But the lowest scale domain score obtained after collecting initial feedback was 82% in domain 3. And the nominal data collected in the final question, yes with modifications, or no, all 3 appraisers selected the yes with modifications. These are the results continued. This is the comparison of total possible points to total awarded points for each domain. As you can see, the dark gray is the total points possible, to whereas the light gray is the total points awarded by appraisers. And you can see here in domain 3 that the awarded points by appraisers is significantly less than the total points possible. As far as limitations for this project go, the small numbers of individuals reviewing the policy could affect the results. There was only 3. The researcher was included in one of the 3. The sample size can always impact overall results of research, even though specifically it was not a sample size, it was just the amount of appraisers that were involved in reviewing this tool. As discussed earlier, there were 3. There was one, they were all involved with the quality improvement initiatives to decrease hospital-associated infections. So they are involved in that aspect, and they also are involved in the policies and adoption processes within the hospital. Bias from the research being an appraiser can also occur. Maybe I felt, because I was one of the appraisers, I guess it's just thought that I would score myself slightly differently. I feel that my scores that I gave the policy written was very similar to the appraisers as well, due to key pieces of information missing that needed to be included to score higher in domain 3. As for the discussion, the results basically meant that the policy needed to be edited before it was adopted into practice. It was not ready to be adopted into practices. There were some minor changes that needed to be made, and it was discovered that some simple information, key information, was missing that needed to be included. For the Agree Tool 2, the policy needed to include a renewal date, and that is standard for all clinical practice guidelines. They need to state a renewal date so that the policy does not go out of date, because as we discussed earlier in the PowerPoint, the original policy, or the policy that's in place right now, is out of date and it does not reflect current practice guidelines. So it is important to have a renewal date so that these policies can be reviewed, and if new research comes out and changes need to be made, at least it will be updated and also be looked at when the renewal date is coming near. And the other thing it was missing was a purpose statement. This was just a simple mistake that it must have just been not added but a purpose statement for the reasoning for the policy needs to be added. So once the additions are made, the appraisers will likely to adopt the policy into practice. This will impact the hospital by allowing for a new policy to be set in place. For a new policy, normally there will need to be education on this policy to discuss expectations and proper central line maintenance care. Usually when new policies are adopted, there's always an education period, because if we just adopt policies into practice, no one's going to know that a new policy was created and they wouldn't be able to properly follow it. So with this education, it also should be seen that central lines infections also decrease. Implications for practice. This will impact patients by implementing a standardized practice throughout the hospital. This is important because when new nurses start working at the hospital, they will be able to successfully find the expectation that the policy enforces. Just from personal experience as a travel nurse, I did heavily rely on policies at times if I wasn't entirely sure what the hospital practiced there, because just because one hospital does one thing doesn't mean that another hospital does it the same way. Even though there are some things such as central line maintenance that should be done very similarly across all hospitals, at least now there is a policy in place that states this is how this hospital does it. Everyone who takes care of central lines will be in agreement of how maintenance must be done. There should be no question, especially when there is a question of how something is done. Usually the policy is brought up to ensure that everyone is on the same page. There is, they do in that hospital have infection prevention rounds. When they come around, at least there won't be any second guessing. Infection prevention will be aware of this new policy and the expectations it holds, so it can be enforced. Overall, the nursing practice, patients, and the healthcare community will benefit from a standardized central line maintenance because it will decrease infection rates and risks. Overall, the impact that this project has made is setting a standardized practice for central line maintenance across an entire hospital. It's going to change how every unit and every floor takes care of these central lines, and it creates that standardized practice. And it's important because if we are all doing it the same, it is easier to identify if there is a problem, where this problem is coming from. Once it becomes adopted into practice, education will begin, and the staff should be aware of the changes and the importance of central line maintenance. Sometimes doing education and stressing the importance of these central lines and how the hospitals are the one that causes these central lines makes nurses and other staff more aware when they are taking care of these lines. Because these central lines can be very detrimental to patients and can prolong hospital stays and increase the risk of death. During this entire DNP process, I noticed that myself, I have been more self-aware, and mindful to my patients that have central lines. I have been on several now in the hospital, I guess, hospital-associated infections and like risk management, quality improvement meetings I have participated in. I have taken some initiative on leading some quality improvement initiatives and and things like that. Getting my DNP definitely has increased my education, and the process has definitely taught me a lot about getting this higher degree and higher education, and how the entire process from beginning to end is done and how long it can take, but also the rewards that it holds at the end of when you complete a project. Even though I feel like the policy is going to be adopted, and it is somewhat an end. I don't think it is entirely the end of, these standardized practices for central line maintenance, and still continuing to take initiative for um, these infections, because they are important and they don't go away, and there's always things that we could do to improve, to help patients and make sure that we are not causing harm, because they're not in the hospital. They're already sick in the hospital. We don't want to do more harm to them. And these are my references. And that is it. Thank you.